Greetings and welcome to the Living Beyond Breast Cancer Digital Health Information, Media Coverage, and Impact on Patients webinar. At this time, all participants are in a listen-only mode. If you have not already done so, please close all other programs on your computer. You may submit questions via the web at any time by typing them in the Ask a Question field on the left side of your screen. There's also an audience chat for you to use located in the left side of your screen as well. If anyone should require operator technical assistance during the conference and are connected by phone, please press *0 on your telephone keypad. For technical assistance on the webcast, click the question mark on the upper right corner of your screen. It is now my pleasure to introduce our host, Stephanie Washburn. Please go ahead.
Hello, everyone, and welcome to today's Healthcare Provider Program, Digital Health Information, Media Coverage, and Impact on Patients. We're happy you could join us. My name is Stephanie Washburn, and I'm the Manager of Healthcare Provider Outreach at Living Beyond Breast Cancer, or LBBC. I'm pleased to serve as your moderator for the program. This webinar is part of LBBC's Young Women's Initiative, which provides resources tailored to meet the specific needs of women diagnosed with breast cancer before age 45. LBBC has been providing programs for young women since we were founded almost 30 years ago. Our Young Women's Initiative began in 2011 when we were awarded a cooperative agreement with the Centers for Disease Control and Prevention to expand and strengthen our programs for young women. And this CDC funding continues today. Each year, we serve over 100,000 young women and their loved ones through the many programs and resources available through the Young Women's Initiative. We selected today's topic because of its importance to people with breast cancer and the increasing need for providers and patients to effectively manage the flow of digital health information and its coverage in the media. Our objectives today are to define health literacy and digital health literacy, discuss how health literacy affects patient understanding of health information, list the challenges faced by patients in evaluating digital health information, outline how using plain language can help patients understand health information. Sue will also describe how social determinants of health, culture, and personal beliefs may influence how patients interpret health information. We'll outline how media coverage affects patient understanding of cancer and medical decision-making, and discuss tips and resources for communicating with patients about health media reports. I'd like to thank our speaker, Sue Friedman of Force, for sharing her time and expertise on these important topics. You'll learn more about Sue shortly. Before moving on to our presentation, I'd like to briefly highlight several LBBC resources. We will be sharing links to these resources by email after the webinar so you can learn more and share the information with your patients. First, our virtual June Wellness Summit. This two-part series begins this evening and concludes on June 23rd. The two sessions will cover nutrition and exercise essentials for people with breast cancer. Please let your patients know about this program and feel free to join us as well if you'd like. And we've recently developed two resource hubs for patients. One is for people newly diagnosed with early-stage breast cancer, and the other is for people with newly diagnosed metastatic breast cancer. Both hubs offer dedicated resources about diagnosis and treatment, coping and relationships, and more. The final hub is for healthcare providers with information specifically for you and resources to pass along to your patients. Now, let's move on to a final few details before the presentation. During Sue's presentation, we will be asking you to respond in the chat at several different points. You should see the chat box on the left side of your screen underneath the Ask a Question box, which we will also be using during the program. We are recording the session and will post it next week on lbbc.org, so you'll be able to watch again. We will notify you via email when the recording has been posted. One additional housekeeping note, we'll be emailing you a link to our program evaluation today. Your feedback is very important to us in planning future healthcare provider webinars, and we appreciate you taking the time to complete the evaluation. If you have registered to receive nursing contact hours or social work CEs for today's program, you are required to participate in the entire live webinar and complete the online evaluation by Wednesday, June 30th. You will then be emailed your continuing education certificate by July 21st. This activity has been approved by the Ohio Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation, and by the National Association of Social Workers for 1.5 contact hours or CEs. Our speaker and planning committee members report no conflicts of interest for this continuing education activity. It's now my pleasure to introduce our expert speaker. Sue Friedman, DVM, was a practicing small animal veterinarian when she was diagnosed with breast cancer at age 33, and afterwards learned she carried a BRCA2 mutation. After her diagnosis, Sue recognized gaps in information and resources for people making medical decisions around hereditary breast, ovarian, and related cancers. She was determined that no one else should face hereditary cancer alone. After finishing treatment, in 1999, Sue founded Facing Our Risk of Cancer Empowered, known commonly as FORCE, to fill the information void for people facing adult hereditary cancer and help them advocate for themselves. In 2006, Sue lost her father to metastatic hereditary prostate cancer. As founder and executive director of FORCE, Sue has 21 years of experience assessing and addressing the unique needs of individuals and families affected by inherited mutations associated with hereditary cancers. FORCE, a nonprofit, has developed and implemented education, resource, and advocacy efforts under Sue's direction. FORCE serves a diverse population across the hereditary cancer care continuum, including the newly diagnosed, people living with cancer, previvors, caregivers, and relatives. We're grateful to Sue for sharing her knowledge about digital health information and are honored to have her with us today. Sue, at this time, I'll turn the presentation over to you.
Thank you so much, Stephanie. I really appreciate this opportunity to talk about a topic that I'm really passionate about and really help the audience and those of you who are attending this webinar kind of get the full experience of how patients and people in the general population are experiencing information and health information, especially in the digital space. And, you know, we know with the pandemic, this has become more important than ever. Just a couple of notes about FORCE and our collaborators on this effort. As Stephanie said, FORCE is a national nonprofit organization. It stands for Facing Our Risk of Cancer Empowered. This particular work is supported by a cooperative agreement with the Centers for Disease Control, and the opinions expressed are my own. This presentation has been developed in partnership with health communication researchers at the University of South Florida, with Susan G. Komen, the National Society of Genetic Counselors, and the Academy of Oncology Nurse and Patient Navigators. And I know that Stephanie has already gone over the objectives, so I won't spend a lot of time on this slide, but just leave it up for a few seconds to remind you what the objectives are. So I'm going to start with a few definitions and talk a little bit about the interconnection between health literacy, jargon, and plain language. And you see a quote that was actually from a patient survey that we did in collaboration with Living Beyond Breast Cancer. And one of our respondents said, "I didn't understand any of my test results, despite asking my doctor to explain on more than one occasion." We know that language and communication and jargon really affect individuals' abilities to understand the information about their health and use it to stay healthy. I want to start by defining health literacy. I think most of us know the more standard definition of health literacy, that's a personal health literacy. So we talk about people, the degree to which individuals and people have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. So really that puts a lot of the pressure on the person, the individual, to have that knowledge, to be able to navigate the health system. But more recently, This isn't a recent term, but more recently, the term organizational health literacy was adopted by the CDC and introduced into Healthy People 2030. And organizational health literacy really involves all of us, and it talks about the degree to which organizations equitably enable individuals to find, understand, use information and services to inform health-related decisions and actions for themselves and others. So it flips the script a little bit, and it really puts the pressure on all of us, anyone who's developing information, anyone who's speaking with patients, anyone in the caregiving and community health worker space, to make sure that the information that we're delivering is understandable and usable and in an equitable way. People have language barriers, they may have accessibility barriers, and making sure that we are taking that into account to the best of our abilities. And so, you know, the challenge is for all organizations, for all of us in the healthcare space to be part of this continuum of health literacy. This is a societal issue, and so we need to all work together to make sure that we're addressing it rather than putting the pressure on the patient to have the skills that they need to navigate the health system, which can be hard to navigate. As part of our work in the cooperative agreement, we started with a needs assessment of community health workers, oncology nurse navigators, and genetic counselors to try and understand some of the barriers to referral to common services, especially focused on you know, individuals who have been diagnosed with or who are at high risk for breast cancer. And in that survey, we did ask these three sets of health professionals, healthcare professionals, and community health workers, actually also included volunteers, to tell us what they found were the most important barriers to referral of patients to these services. And, you know, no surprise, but jargon and health literacy were chosen as one of the top 3 barriers to referral for clinical trials, and also for referrals to genetic counseling and genetic testing services, and I will add also for preventive services as well. So this is probably not a surprise to any of us. We know that the medical community, all of us, are kind of guilty of this. We use jargon, we use information that is shorthand for us. It makes communications perhaps go a little quicker, but a lot of times what we're doing is leaving people behind because they don't understand the jargon, and it can be off-putting. And we know, and I won't spend too much information on this, too much time on this, but we do know that if we can enhance health literacy among patients, then it improves access to care, and especially access to preventive services, improved ability for patients to communicate with their healthcare professionals. We're empowering them to talk in a language that they can understand and we can understand, and make sure that we're all on the same page. And that, it improves medical compliance. If patients understand what instructions are for medications, they're going to be more likely to follow them. If they know about what the side effects are, or when they should contact healthcare professionals to let them know they're having side effects. Again, all of these things are safety and long-term health outcome issues. And it does improve self-care, people's ability to take care of themselves, stay healthy, avoid trips to the emergency room, that type of thing. And that's been well documented. It's also important to remember, though, that when we're providing health information, and when the general public is accessing health information, that they're going to filter it through a very personal lens. Each person is different, and even through the course of their lifetime, or even moment to moment, that can affect the information that they choose to look at and how they interpret it. And so there's a lot of different filters that influence how and whether a person even looks at information, and then how they interpret it. And some of those things I'll go over here, and we'll go over in a little bit more detail, including the social determinants of health. These are things that can affect how people get access to care and how they interpret it, personal experiences and beliefs. And, this is important when we're choosing ways to communicate with people. Even something like the photograph or the graphic that we choose may make a person either relate to it and think this article is about me or not. And so if we're choosing only photos of, cisgendered, heterosexual couples, then, people who don't fit those categories, people who are not in a relationship, people who are transgender may not believe that the information in that article even relates to them based solely on a graphic or a title. So it's important for all of us to be thoughtful about the ways that we deliver information and how we communicate it, and even, as I said, the graphics that we use accompanying it. We know from some of the focus groups that we've done at Force that, and I'm sure many of our partners know this, and many of you on the phone, that diagnosis and stage also affect the types of information that people are looking for. We know that people with early stage breast cancer may not be as interested in articles about metastatic cancer, and the same is true about individuals with metastatic breast cancer who may not be as interested in articles about cancer prevention. They may be, but they may not be. And we know that there are preferences based on where someone is in their care continuum and on their healthcare experience. And things like personal beliefs. We know that there's a lot of strong opinions about vaccines. So even choosing the term vaccine in an article or on a patient brochure or how we communicate can lead to people having strong reactions, even if, the article itself isn't necessarily about the types of vaccines that, they're thinking of. So our word choice can really affect how people look at an article, or even if they pick up the article and read it. And then, dietary preferences, things that people are hearing that they should be avoiding or eating. A lot of that is, personal belief, and it's also influenced by culture and other factors as well. And then trust and distrust in the medical community can also affect how, what types of treatments and what types of information people read and pursue. So I want to pivot a little bit to what we call digital health literacy or eHealth literacy. So this is, relatively speaking, relative to the definition of health literacy, this is somewhat of a new term. It's very similar, the definition itself is very similar to the definition of health literacy, but it just acknowledges the fact that the digital space, that people getting information delivered in the digital space can be a little bit different. And in some ways it can be fraught with some traps, which I'll go over later in a few slides. So when we're talking about digital health literacy, we're still talking about an individual's ability to seek, understand, and assess electronic health information and apply that knowledge to address a health issue or a problem. So very similar to health literacy, but it really speaks specifically to the electronic nature of the information. So I know I said that we would go over the social determinants of health. So this is where we're going to kind of do an activity in a moment. So on the left is a wheel with the 5 domains of the social determinants of health. These are things in a person's environment, in their situation, that can affect their access to information and healthcare. And these 5 things include healthcare access and quality, the neighborhood and built environment, social and community context, economic stability, and education access and quality. And so what we're going to do in the next activity, and I'm going to ask you to, and there's no right or wrong answer here. This is an opportunity for us to learn from each other. I'm going to go around to each of these 5 domains, and I'd like us to think about as a group how each of them affects people's ability to find, understand, assess, and then utilize the health information for their health care. So we're going to get started, and I'm going to ask people to type your answers in the chat, and we'll see how it goes. So this is just an overview again of what we're going to do now. So let's start with economic stability. Does anybody on the call, and again, if you can type your answer in the chat, have thoughts about how economic stability may affect a person's ability to find, understand, assess, and apply information, health information? And we'll give people a moment to type and think about it a little bit. And I have some prompts. Okay, good. I see that we're getting some answers in there. Ability to pay for provider visits and or treatment. Absolutely. That's a really important one.
Yeah, Sue, there are a lot of great
else?
responses. Yeah. If you'd like me to try to help summarize, I'm happy to.
That would be great.
Okay, wonderful. So I'm seeing some here, and I know I'm not going to be able to get all of them because there are just so many. But I'm seeing transportation show up, transportation to their visits, as you noted, some responses related to internet access and the inability to afford that. Parking fees, again, kind of connected to the whole transportation element. Somebody has a great point about not having a smartphone for telehealth. And we have another one that includes time and energy, and then child and elder care. So I think there are a lot of really interesting responses here.
Excellent. I think you guys nailed it. You did a great job. So, you know, here are just a few that I had come up with ahead of time, and I think you guys got all of these. These are really great. Too busy working, taking care of the family. You don't have time to focus on your health. Someone said the cost of a smartphone. Absolutely. Computers or internet service. Cost of health insurance, office visits, medication, and other care, you know, again, the time off work. And then the transportation aspects of it, the ability to go to appointments, participate in clinical trials, travel for care. Absolutely, that is great. You guys have already gotten the hang of it. And I will also tell you that every time I run through this presentation, I learn something from the audience. So thank you so very much. We will use your contributions for the next time that we have the opportunity to present. So I really appreciate these thoughtful answers. Okay, let's go to the next one, education access and quality. And I'm not able to monitor the chat. I think it kind of fell below the fold for me. Are we getting any responses there?
Yes, there are a lot of really great responses, Sue. There are a number related to challenges with navigating the internet, cognitive ability, access to people to get help understanding what one is reading, limited ability to read and write, physicians not taking into account people's different comprehension levels and literacy levels. So there are a lot. They are still coming. I'll stop there just in the interest of time, but this is a really impressive audience.
I know, I'm so impressed. I'm hoping you'll be able to print these out for us later so that I can definitely take advantage of the great minds in the audience. I really appreciate it. I think that you guys hit on many of the highlights, and I know that, really you could spend a lot of time thinking about these, and that's really kind of the point of the presentation, that we spend some time thinking about it because, really part of the goal of this is to look at the digital space from the patient perspective so that when we communicate with patients, we're making sure that we're understanding each of these challenges that they're facing. So I'll go over some of the things that, that I wrote out. Certainly grade level and health literacy are the things like the highest grade level achieved can affect health literacy, but we know that that's not always the, the only thing that matters. Certainly it's the types of things that were studied and people who didn't study science. There are people with PhDs in areas that don't relate to science, and they may have difficulty understanding health issues, and that makes sense. Of course, issues like numeracy, understanding statistical concepts like risk, we see that a lot. Even being taught critical thinking skills. With regard to understanding and accessing the internet, I think that's a really good point, and there are definitely generational differences, and I'm going to show my age, but what we see is that students and people who are graduating now have a lot more computer education and computer knowledge and comfort with being on using digital devices than many in my generation and older, where we didn't grow up accessing computers. And even things like access to student health services, and the link between education and employment. So there's overlap too between some of these social determinants of health, where the education affects also the financial aspects and the economic stability. Great. You guys are doing a great job. Okay, so let's talk about healthcare access and quality and how that may affect health literacy.
So I'll keep my eye on responses as they come in and let you know what everybody has to say.
Excellent. I'm so happy. We do not have a very shy audience. This is great.
I know it is. They are wonderful. So I'm just going to give others a few moments to add theirs, and then I'll jump in. Here they all come. Wow. All right. Good stuff. Okay. So let's see, I am seeing people having a long distance to get to treatment. They live in a rural area, insurance issues, high deductibles, lack of trust in providers or the hospital system, such an important one. People not being able to afford their copays, a lack of inclusiveness, loss of job, no specialists in their area, childcare issues. Again, the urban versus rural difference, and insurance that limits options to just a certain network. So again, in the interest of time, I will stop there, but that is by no means comprehensive of all of the great responses.
But those were the major ones that I can think of, and that's just great. I mean, access to providers who are knowledgeable, that continuity of care, being able to see the same doctors and specialists, or even access to specialists. Again, a lot of times limited by people's health plan. Even the ability to get a diagnosis so that you can get more information. Access to patient portals. So many of us use patient portals, but that really depends on the health system that you're using, and if they have a patient portal that is easy to navigate, and with access to all the test results that you may have. I mean, those things, being able to put all that information together really helps people be able to navigate the healthcare system. Of course, insurance coverage, and then the access and proximity to comprehensive medical centers and that coordination of care that really can improve health outcomes for people. Excellent. This is great. So let's talk about social and community context. This is always a really interesting one, because that community context really expands once you're talking about a digital realm. So let's see what people come up with.
All right, I will share some responses with you shortly as people start putting them in.
Excellent. And actually, I see a question here about, does this question relate to digital health literacy or access to healthcare? The two are related, because when you think of that last circle, the applying the information, then it is about access to healthcare. And there is a big overlap between health information and digital health information. So I would say the answer is really both.
Great, thank you for noticing that and answering that. Well, in the interim, people have, we have many responses. Cultural beliefs, fear of asking questions, distrust, influence of cultural preferences or religious beliefs, support systems, mental health support, let me just see, skepticism and mistrust. So I think those are the primary ones that I am noticing, but again, that is most likely not comprehensive of all of them, but some great examples.
That is great. I think that is most of them. I do think, and I'd like people to consider too, when we talk about where people access their information and support, so, you know, we do think of it oftentimes in their immediate environment, their social circle, their family and peers, but there's also the online peers as well, the unmoderated peer groups versus the expert-led peer support groups. And, you know, sometimes there's differences there in the type of information people receive. It was already stated, because you guys are, you know, great and you know, coming up with some great ideas, trust and distrust with the healthcare system. And that really, again, relates to that personal lens as well, but can also be, you know, about your family's experience with the healthcare system. And there are cultural beliefs about wellness and preventive care versus treatment, that type of thing. Family experiences, as I just said, and then cultural factors that may affect things like lifestyle and diet. And healthcare decisions. And then the places where people gather, and the opinions of trusted community leaders. So that can be the faith-based leaders, that can be teachers, that can be elected officials, and, you know, online, that can be, you know, advocates, that can be influencers and, you know, bloggers. And so all of those different areas can affect how people get information, the type of information they get, and their ability to assess it for how credible it is, and then how they apply it. Excellent. You guys are great. Okay, last one, and then we'll move on, and that is the neighborhood and built environment.
All right, Sue, I am monitoring the chat. We'll give you some feedback in a moment from our audience.
And I'm seeing a question right here in front of me, so I'll answer it. Will you be addressing how media covers health information and the impact that has on cancer patients? Absolutely.
Great, thank you. All right, so we are seeing all sorts of responses coming here. I'm seeing transportation again, environmental racism, no internet service in the area, limited access to health care, safety as such an important concern, lack of access to computers, distance from libraries, distance from hospitals. So let's see how accessible the doctor's office is for persons with disabilities. So all sorts of great examples again for you, Sue.
These are great, and you know, I love it. And again, I'm going to see if there's any way to print out this chat for me later, because I've already heard some things that I have not incorporated that I will be. You know, the ones that I do have, reliable internet, absolutely. Do people have access to libraries? Libraries can be a real source of access to internet services. How far people have to travel for healthcare? What type of healthcare services are nearby? Transportation options, environmental racism. Wow, that is one I'm going to be adding. That is really a thoughtful answer. And again, we could probably do this for an hour and come up with new thoughts on this. So I really appreciate all of you providing me and all of us with your insights on this, and to whatever degree we can, I'd love to capture it and share it out, because you guys are a source of information for me. Hopefully I'm a source of information for you as well. But you know, this is fantastic, and you guys are really great at thinking about these things. So thank you so much.
Sue, just to answer your question, and then I will mute myself so you can keep going. We are in touch right now with Income about how we can get that chat for you. So we're going to do our best for you on that because there have been so many great things entered. I know you want to make sure you can take that with you.
If possible. If not, you guys can email me your thoughts later after. This is really great because, you know, this presentation really is meant to be interactive, and it's a work in progress. You know, we keep improving on it based on input from our audiences. So really know that you're having an effect on how we, you know, how we improve and improve on this presentation. Okay, so that was great. We're going to move on now to the idea, the traps of online information, the things that make digital information fraught and challenging for patients you know, and caregivers and the general public. Because there are things that are specific to the digital space that make it even more challenging than any information. Although many of these things do apply for any information, they're particularly challenging in the digital space. So I'm going to go through a few, and there are probably more. There's probably at least one other that I'll bring up that I don't have a slide on. But, you know, just off the bat, contradictory information. So this is an example. The article on the left and the article on the right are media coverage of the same peer-reviewed journal article. And so, you know, there are some ways that people could potentially discern the differences, but, you know, your average person may not look beyond the headlines. And so, you know, the one on the left says drinking milk doesn't cause breast cancer, and the one on the right says that drinking milk and dairy consumption is linked to a spike in breast cancer. So, you know, unfortunately, sometimes when people are confronted with contradictory information, rather than trying to determine which is the correct or the more accurate information, they may throw up their hands and say, nobody knows, see, you know, and just make, you know, look at them equivalently. So just important to understand that when, you know, when we're communicating with people, because, you know, for those of you who are healthcare professionals, you may be very, very careful about the information that you're providing, and advocates or anyone else who's delivering health information in this audience. You may be very careful with how you're delivering information, but I think it's equally important to recognize that once a patient leaves your care, once they leave your office, once they hang up from the phone, then these are the types of things they're confronted with. And just really understanding that will help us kind of figure out ways that we can inoculate people, if we can, against some of these traps. Extensive. I mean, this is pretty obvious, and you know, within less than a second, someone can Google breast cancer and get 478 million pieces of information. And although there are some algorithms, they're not always applied in a way that puts the most credible information first. And so, you know, in a lifetime, someone's not going to be able to go through 478 million pieces of information. So, you know, how are they to tell what's the most important information for them? And, you know, a lot of it outside of the, you know, like media coverage of articles is this unmoderated area of just people's opinion. So even if the media covers an article and they're doing it accurately, you get this area where, you know, people are providing commentary. And a lot of times these commentaries, and I don't know how many people here actually look at some of the commentaries for some of these articles, but there's a lot of conspiracy theories and, you know, people just throwing out there, well, you know, if it's been approved for breast cancer, why can't it be approved for lung cancer? You know, these ideas that, that the cure is out there and it's being withheld, those types of things that go unchallenged and unchecked, and, you know, people are seeing that. And there's a sense of, you know, a bit of confirmation bias if they already believe it, and then they see it again, they're more likely to believe that it must be real the more times people see it. Inaccurate information. So this article on the left was an article that actually got a lot of coverage in the, you know, in the national news, even though it started at a local media outlet, about a woman who was in a clinical trial. And this was an interview with a woman, and it was great. I mean, we want people to participate in clinical trials, and we want them to feel good about it. But when we saw the article and the media coverage, we went to pull the peer-reviewed journal article to see, what has been published in the peer-reviewed space on this information, and there wasn't anything. And to the best of our ability, what we can tell about this article was that it started with an interview with a patient, and quoted the patient saying that, that this treatment helped her. But this was a patient with early stage breast cancer, and she also got standard of care treatment. And so importantly, it's too soon to know that this vaccine trial really helped her or treated her at this point. I mean, it was a phase 1 clinical trial. On the right is a trap that I kind of came across just every day. I was watching my news feed, and this was an article this was a report on TV about a new variant. They were talking about COVID variants, and what they did was they presented what was a relative risk as an absolute risk. So it says, a new study, UK variant may have higher mortality rate, perhaps as high as 61%. Well, to my knowledge, there is no COVID variant with a 61% mortality rate. I mean, that is huge and scary. But, and they probably had limited space, so it would have been hard to say, variant has 61% higher mortality rate than original variant or whatever they were comparing it to. But, when they present it this way, it looks like an absolute risk. And then this type of information gets shared. This is one we see a lot, information sensationalized. Any of you who may have been in the healthcare field or an advocate a few years ago may remember this Jerusalem Post article. It was an interview with 2 scientists who had started a company, and they were saying they would have a cure for cancer in a year. 2 years later, by the way, fast forward, there is no cure, and certainly not that they developed. And there were a lot of red flags about that article, but it got a lot of national press coverage. Actually, the press in general did pretty well, other than the original Jerusalem Post article, which was pretty sensational. And, we see articles that are based on science, and they may even be scientifically accurate, but the headlines have things like magic bullet or holy grail, and we have to be really careful of those types of terms because oftentimes they are sensationalizing it to get people to click on it, which makes sense because, that traffic to a website is monetized. And so there's incentive to get people to click on the article. And sometimes the articles themselves are, not that bad, but it's the headline and the lead that are really sensationalized. So, and many people may pass on articles, but only read the headline, or they may only read the headline, and that's kind of as far as they go in digging to the article itself and the science. Lacking context, this is one we see a lot. There may be some really legitimate science being presented, but how it's being presented is really missing. It's kind of back to that phase 1 clinical trial that was saying that, this vaccine treated a woman with breast cancer. You can only imagine we're an organization that, helps people with inherited mutations, including people with BRCA1 mutations that the Daily Mail loves to call the Angelina Jolie gene. And you can only imagine how a group of individuals with a BRCA1 mutation may react to an article saying it's been linked to Alzheimer's. So, needless to say, we did some research on it. We found the peer-reviewed journal article, and this was really an article that it was a basic science study looking at a new model for Alzheimer's disease. The science was not designed to show a link between BRCA1 and Alzheimer's disease, and it didn't. And so it was unfortunate and caused a lot of concern among people because they didn't provide the context that this wasn't a study meant to link these two things together, and the study was on mice. and also the brains of people who had died of Alzheimer's disease. But again, if you look at Angelina Jolie gene may be linked to Alzheimer's, it's quite a bit out of context. And, for people who can, try and access that information that is, in a peer-reviewed journal, perhaps they know where to go for that information. Oftentimes that information is full of jargon. We talked about jargon before, and not, it's not very accessible to patients. And then, again, if they know where to get it, sometimes it's locked behind a paywall. You have to pay for it to get, the information. And, the other one that I'll add, even though I don't have a slide on it, but just to mention, and this came up from another presentation, which is why I'm so eager to get all of your guys' responses and great comments, is that retargeting, that, just because someone clicked on something, they did a search for a particular, I actually did the exercise looking for COVID and side effects on YouTube and ended up with a lot of suggestions for other videos about, strange side effects from COVID vaccines. And so, again, that plays into that confirmational bias. If people think that there's, something there that's really important for them to know that, may be sensationalized, and they do a search for it, they're likely to get more suggestions for more content that's related to that. And it may provide this sense that this is really important because it's getting a lot of coverage. And, just looking at my feed, looking at the suggestions that YouTube is making for me, it must mean that this is something real. So, so that's another trap that we see. So we're going to stop for a minute and just take a quick poll. I'd like you guys to think about, of the traps of digital health information that are listed below, which one do you think poses the most harm to patients? And this is just really to take the pulse of the audience. There's no right or wrong here. I'm just, mostly for my own information too. So we'll give you guys a minute. They'll queue up the poll, and that will allow you to provide your answers, and then we'll take a look at what everybody said.
Great, thank you. So Diego, will you be able to launch the poll for us?
Yes, the poll is currently launched.
Wonderful, thank you.
Excellent. Good. We'll give people a few more seconds to think about it. Let's give it 3 more seconds if you don't mind. We're still getting a few answers in. Great. I think we're ready to share the results with the audience. And I can't tell, is the audience, I'm sorry, are they seeing the results?
Yes, Diego, let us know the results have been shared.
Oh, excellent, thank you. Sorry, I wasn't monitoring that part of it. So it looks like a lot of people felt like, they were all equally harmful. And then sensationalization and inaccuracy were also really high. Lacking expert review, they're all kind of related. And a lot of times, problematic media coverage has more than one trap in it. So this is really excellent. I really appreciate you guys giving some thought to it because I think it's, again, really important for those of us who are developing information, those of us who are communicating with patients, to really think about, what they are confronted with and the challenges that they're facing as they navigate this space. Okay, so we'll go back to the presentation then. And thank you, everybody, for participating in that. So I'm going to give you an example. And again, you know, because FORCE is an organization that focuses a lot on hereditary cancers and inherited risk, that this is one that we saw. So this is how we actually hear about a lot of these examples. We monitor, we do social media listening, we hear from our volunteers, we hear from our constituents, and they will send us articles and say, what do you think of this? Or I just heard about this. So this is kind of an example, and it's a real world example, or kind of a, you know, a conglomerate of real world examples. But, you know, this is a person who has a BRCA mutation, and their risk for breast cancer is very high, and they've been really grappling with whether or not they want to have a mastectomy and when, and, you know, the timing of it, and they've put a lot of thought into it, and they have, after, you know, a couple of years and really discussing it and really thinking about and looking at timing, they decide to schedule their bilateral risk-reducing mastectomy. And it's going to be in a couple of weeks. And then their father sends them this article, and it could be, you know, usually these are very well-intentioned relatives or people care about them, and they send them this article. I had a mastectomy to lessen my risk for breast cancer. Does science say that was a mistake? You know, you can only imagine, even if the content is no, science doesn't say that's a mistake, just seeing that, the emotional reaction, someone who's really thought hard about it, and, you know, even it can play into fears about timing and, you know, like, this must be fate. I just got this article just came out. Maybe it's trying to tell me something. I mean, these things can have an effect on patients' decision-making beyond what the science says. So, you know, the peer-reviewed journal article was actually about classifying BRCA1 variants of uncertain significance. So this was a really cool article looking at, you know, new techniques to take these, what they are called variants of uncertain significance, or VUS. These are inconclusive BRCA or other genetic test results. So, you know, someone has a change in their gene, but, you know, there hasn't been enough testing to determine if this is linked to cancer or not. So this article and the research was about, can we do a better job in figuring out some of these inconclusive test results? And, you know, it turned out that when you read the article, and I'll go back, when you read this article, it's actually, you know, a pretty well done piece by a journalist who did have a mutation, but they had a known mutation. They did not have a variant of uncertain significance. So, you know, science didn't say that it was a mistake, but that headline can have an emotional reaction on patients. So we're going to do a little activity. I like to call it pin the tail on the donkey, or, you know, pin the journal article to the media coverage. And again, it's really just, this is meant to be a little bit hard. It's really meant to show that there is a mismatch between, you know, the peer-reviewed journal article and titles, and how the media covers it and their titles. So just to get you started, and hopefully people can see this big enough to read it, but the first one was the one that we did. So on the left is the peer-reviewed journal article, Accurate Classification of BRCA1 Variants with Saturation Genome Editing. So as we do this activity, we already know, because I just went over it, this was the headline that was linked to that article. So I'm going to queue up another article, and I might have to read it for you so that you can see it. So this one says, expression and functionality of TRPV1 in breast cancer cells. So if you look on the right, does anyone, and you can put your answers in the chat, of the other media headlines, which one do you think this might relate to? And again, this is meant to be hard. It's not.
And just a reminder for the audience to please use the chat for your responses as opposed to the question section. You can feel free to use the question section throughout the program to put in questions you'd like Sue to answer when we have a little time dedicated for that at the end. But again, please use the chat for responding to these questions during the program. And Sue, just let me know when you'd like me to let you know what I'm seeing here.
Yeah, you can go ahead and let me know what you're seeing.
All right, I am seeing chilies, antioxidants, stunning allegation, tech and science, DNA test. I'm trying to see if I can really find a trend here. They do come in so quickly, it's a little bit hard to say. So I would say that's my general sense so far of what
Yes.
people have said.
Okay, and there are only 5 options anyway. So, so it is red hot chili peppers, and I like this as an example. The peer-reviewed journal article was a basic science article. There was really nothing about that science that said that eating red hot chili peppers would, help you stay healthy or prevent breast cancer metastasis. But chilies are cool, and they show up nicely on the headlines. Great, let's do the next one. Oxidative stress inhibits distant metastasis by human melanoma cells.
I'm just waiting for responses here, Sue, and I will let you know.
Okay.
I see. Let's see, it looks like somebody thought there might have been a connection to that one with chili peppers. Antioxidants, seeing a lot with that. That seems to be our trend here.
Yes, and that is it. And, I like this one because the headline is just so comical. Antioxidants are good for you until you get cancer and they feed the disease. That really is not what that article said, the peer-reviewed journal article, but, it's a really catchy headline. Okay, next one. Gaps in incorporating germline genetic testing into treatment decision-making for early-stage breast cancer.
Just awaiting responses. Let's see. Get cancer, DNA, stunning allegation. Seeing a lot of stunning allegation, some on DNA tests as well.
Excellent. It is stunning allegation. Half of all mastectomy patients do not have cancer gene. Misreading data. Again, just a very sensational headline. And, really this was about, people not necessarily having genetic testing results in order to guide their treatment decision-making. There was nothing stunning or an allegation about it. But, this, again, because, we've monetized the traffic through websites and media websites, it's a lot more compelling to have a headline that makes people click on it. Thank you guys for doing this. Really the point of this exercise is to, put side by side these two very different views of the, this, what's supposed to be the same information, the peer-reviewed journal article versus how the media covers it. So we're going to switch gears a little bit, and I'm going to talk to you a bit about a program that we developed at Force that we've kind of used to address this issue. And then from there, after that, I will talk to you about a few tips for, how to be media savvy, how to help your patients be, a bit more digitally health literate. So the name of this program, we call it Examining the Relevance of Articles for You, or X-ray, the idea of, X-raying an article and looking behind the headlines. And this is what it looks like, and this is a link to the XRAY program. Our program covers the, 7 areas that are a focus for our organization right now, but mostly we're going to be talking about breast cancer, which was the area of the program that was supported by a cooperative agreement from the Centers for Disease Control and Prevention. So, the reason we developed this article is, this program is everything we've talked about up till now, the fact that research articles are technical and they're not necessarily accessible to patients. And the media is accessible, but it's not always reliable. And it's often sensational that often, you'll see a celebrity in there used to, again, make people want to click on it. And so on the left is this same scientific report that we talked about before, the accurate classification of BRCA1 variants. And on the right is the media report. And really, we developed X-ray to kind of bridge the gap between the two. So each X-ray summary provides a overview in as plain language as we can, which is not always easy, especially when you're talking about genetics or cancer, but in as plain language as possible what the research was about. And then we develop these rubrics, these scores that allow people to see at a glance how clinically relevant is this. So really, for someone who's making a decision right now about their care, is this something that's already available to them, or is this basic science that's going to take years before it's developed? And helping them understand, was this something that's generalizable to all people with cancer? Is it more specific for certain populations? And just really an all-up relevant score. Again, meant to be at a glance. We also rate the strength of science. It's not about whether or not the researchers, used good scientific process, although that can be part of it. And, it's looking at things like the limitations, but also the size of the study. Was it a retrospective study? Is it a prospective, randomized clinical trial? Is it a phase 1 study, or is this a registration, a very large multi-institutional phase 3 study? So that type of thing goes into our calculations for the strength of science. And then we tell people where it is on the research timeline so they can see at a glance. This is human research, but it's kind of along the early side of human research. So here's another one. I really like this one. Asparagine bioavailability governs metastasis in a model of breast cancer. So, that already tells you this is about models of breast cancer. It's probably not looking at breast cancer in people. And yet the media report bunked this veggie. This green is responsible for spreading cancer cells to other organs. And, this one got a lot of airplay apparently because as I've presented parts of this presentation and our X-ray coverage of it, we have heard from healthcare professionals who have said, that's why my patients asked me if they should stop eating asparagus. So the way we covered it, for our XRAY program, this was a study that, we said, is asparagus linked to breast cancer metastasis? And actually more recently, we've tried not to make these questions, but say more definitively, what the study concluded in the title so that people can get that right up front. And, you can see the relevance is low. This was a basic science study. And it was animal research. For each review, we also include expert guidelines, clinical trials, and also question prompts. So questions that patients can bring to their doctor about this topic. The reason we included the guidelines is that, depending on what the topic is, we were told in focus groups by patients who use the programs that, sometimes it's like, great, this is new science and it's exciting, but it's not standard of care. What is? So we started to include, if there are relevant expert guidelines, information about that. The other thing that we heard, especially we heard this from people with advanced and metastatic breast cancer and other advanced cancers, was, okay, so there's a new report on a phase 1 clinical trial and it was positive and it's exciting, but it's not standard of care either. How do I get access to the agent or the intervention that they were testing? And normally, usually that's going to be through a clinical trial. So again, if there's any related clinical trials, we include that within the review so that people can find them more easily.
And Sue, if you'll forgive me for interrupting, I just wanted to let you know we have approximately 15 minutes before our, target time to leave 10 minutes for Q&A, but we have some flexibility there. Just wanted to let you know.
Perfect. Thank you so much. I really appreciate that. And I'm finishing up on the XRAY program, but just, a couple more things. The other thing that we do is we rate how the media did in covering it, and we give it 1 to 5 stars. And we developed a rubric and we're transparent. We bullet out why we took stars away from the that particular media coverage. So in the case of I had a mastectomy to lower my risk for cancer, it had some good information in it. We ended up giving it 2 stars. It wasn't really necessarily solid reporting. And for the bunk this veggie, I think that got 1 star. There wasn't really much scientific in that. And then we provide a printer-friendly version so people can easily take it with them to their healthcare professional. It tells them where it came from, so they know that it came from an organization called FORCE. They can look us up. They can actually look up the peer-reviewed journal article if there is one. It has the guidelines on it too, as well as the clinical trials and question prompts, and then of course the summary of the research. And it's searchable, so people can look by date and relevance and keywords, and then by topic. I just want to point out one other thing, and that is this. We have discovered through doing this program, which we've been doing, we have over 200 articles, about 250 in our XRAY library. There's a mismatch between things that are clinically relevant and what the media covers. And so, for example, this was an article that didn't come out too long ago about a component in honeybee venom, and it got all sorts of media coverage. I mean, you can see on the page, even if you can't read it, there are at least 6 different media articles that covered this. And, honeybees are cool, so that makes sense, but this was very early research. I mean, it really does not have clinical relevance right now. On the other hand, these are, a couple of articles. One was on how a breast cancer diagnosis affects employment, and another one about body mass index and how aspirin works on preventing cancer, and both of which were pretty relevant, and really neither of which got much media coverage. So we try and cover those topics as well, because it's important information for people to know if it's clinically relevant, but it might not make the headlines if it doesn't involve, something cool like a honeybee. So we're going to go to the next poll question. Of the features of the XRAY program that I went over, which one do you think would be most helpful for your patient or for patients to see or to have access to? So if you can launch that survey, and we'll give people a minute. And we're still getting some answers. We'll give people 30 more seconds. Excellent. I think we're not getting any more answers, so why don't we go ahead and share the results?
And I believe those are visible now. Is that right, Diego?
That's correct.
Excellent. So this is great. This is great information for us. And great feedback about the program. A lot of people thought it was all equally helpful, and that's great to hear. The plain language summary, I would tend to agree with that. We do know that some people don't go beyond the headline. So it's really important, to have the headline and the lead and the summary really readily available to people so they can get that, for us, certainly we want people to click on our articles, but it's not monetized for us like it is for the media. We want people to get the information that is first and foremost, so it's really important that we're putting the most important information first where they can see it and understand what was this about. Excellent. So we'll go back to the slides. And I appreciate you guys are a great and really engaged audience. So appreciative. So now let's kind of put this into practice. Just a few tips and resources. So here are just some basic strategies. These are techniques to improve health literacy. as an individual, as an organization, and many of these are validated tools that really, weren't developed by us, but we're champions of. One is really just creating awareness about health literacy. One of my new missions is to share this new definition, or it's not new, but, this definition of organizational health literacy, and really try as an organization and as a advocate to take ownership of and responsibility of being health literate myself in the wider sense of the term. And that is making sure that we are equitably providing information in a way that people can use it to stay healthy. And you guys can do that as well, and there's a lot of great resources out there that can help you do that. Using plain language, that's so important. Trying to eliminate that jargon, it's really hard, but the best you can do it. We want people to understand what we're saying, right? There is something called teach back, and that is a concept that has people say back to you what you told them. It's used and taught to healthcare professionals, and there's some really good resources around that. And then this concept of Ask Me 3. So both from the provider perspective, but also educating patients about it too, that, when you go into a healthcare professional's office to, understand what is my main problem, what do you recommend, and why is it important for me to follow this advice? So, plain language, this is an example of a healthcare professional saying your pathology report indicates that your tumor was benign. That's a lot of jargon in there. If we just say you don't have cancer, people can understand what that means the first time they hear it. That may be a more easy example. Sometimes it's really hard because terms like genetics don't always have alternatives that you can use, but to do the best you can and remove as much jargon as possible is great. And then teach back, again, asking patients to repeat back. And I gave you an example of a handout here that's really, meant for the patient to tell them that, if your healthcare professional asks you to share back what you know or what you heard, they're not trying to test you. They want to make sure you understand it, and really getting all of us on board with this. So it's a really great way to make sure that people do understand before they leave your care what it is that you're communicating with them. And, this is just an example, of a doctor asking a patient, so tell me when you plan to take the medication. And then it doesn't sound like a test. And then ask me 3, what is my main problem? What do I need to do now? And why is it important for me to do it? So the next part, though, are some tips and resources that are kind of homegrown. We call it developing your X-ray vision. Many of these are obvious. Probably most of you already use this. But these are also thoughts and ways to approach information that you can impart on patients and other people. In my case, oftentimes I find I'm imparting it on my family members too. In your day-to-day experience of, using information that you find online. And that is really especially to check before passing it on, but before making decisions, try and check what is the source. What is the content, and what is the context and the relevance? Those two are really related. What else do you need to know about how important this is and how closely related this is to your situation as you're making health decisions? So, for the source, looking at the URL extension can be really helpful. .gov are government agencies. They're very reliable. The CDC, the National Institutes of Health, the National Cancer Institute. These are really good, well-vetted sources of information. .edu are academic institutions and universities, and they are usually reliable. And I'll just say one small caveat, and that is watch for press releases, because sometimes press releases about science or research that come out of academic institutions may tend a little bit toward, a little bit toward the sensational side. It's just something that we've observed. Usually academic institutions are really careful about that, but it is a place where that can slip through. .orgs, nonprofit organizations like Force, it's important to know, like, what is their mission? Who's on their advisory board? Do they have an advisory board? Who's on their board of directors? What other types of information do they have? And then .com are commercial, for-profit companies. So, that's not bad, but, what is their business? Who owns it? Are they selling products online? All of these things can influence the type of content and, how reliable it is. Checking the content, and especially, looking at the dates. Is it current? Is it neutral? Is it an article that says breast implants linked to rare cancers are recalled, which is factual information, versus, have 100,000 women been poisoned by their breast implants? Probably not. Worrying evidence of new scandal, looking for terms like scandal or holy grail or cure. Sometimes these are these can be sensationalized as well, and lead to this belief that this is, maybe the science is a little more solid than is really the case. Are experts quoted, and are they legitimate experts? And also, are they legitimate experts in the field that they're being quoted on? Because, in the case of that Jerusalem Post article and the Israeli scientists, if you looked up the publications of the scientists that were, the ones that were being quoted that had started this company, they really didn't have expertise or publications in oncology. So that's important, and it requires digging a little deeper. Are the statistics clear? Does the content make sense? These are all things to check. Confirm before sharing, and this speaks to the expert. This is an example of a chain email that came to me in my inbox and had been forwarded probably by about 100 times before it landed in my inbox. So people were sharing it very freely. And it talked about a Dr. Irene Ken, a professor at Johns Hopkins. And so it didn't take me too long to Google that name, or actually to look on the Johns Hopkins website and look at our faculty and see that there really is no such expert by that name from Johns Hopkins. And then, I went another step and I Googled it, and it turns out that there had been so much misinformation and viral sharing of it that Johns Hopkins created a page saying, this information is not from us. And then you can see Snopes.com on the bottom. Snopes is actually a great fact checker website to look for things that may not really be well-vetted information. And then it's important to look at the context too. Just because the media says it's linked doesn't mean it. Who was the research about? Who were the populations in the study? What phase of the study was it? How many people were in it? Were the results statistically significant? So just making sure that, the context of the research actually relates to the types of decisions and circumstances that people are trying to navigate. And then, is it clinically relevant? So, the article on the left was a study on diet. They were actually looking at soy consumption in patients, versus the article in the upper right, the red hot chili pepper article, was really about looking at a component in chili peppers to see, as a model in, test tube, I think in mice, to see if it, could be used as a model to study metastasis. And, looking for things like FDA approvals. Did the guidelines change? That's always, a big flag that this may be really clinically relevant, because it changed the guidelines, and the professional societies said that. So just putting it into practice, just a quick study, and then we'll stop because I know I'm eating into the Q&A time, but this was an article that actually came out, and, what do you do if a patient brings you this article? And, as someone who has a BRCA gene mutation, reading this and looking at this heart-stopping, really scary photo of salivary glands, I can tell you that it certainly gave me pause. So let me ask you, if you guys can type in the chat, what are some of the things you might do if you had a patient and they came in and they said, I just read this in the Huffington Post. I don't know. Why didn't you tell me that, it's also linked to salivary gland cancer? Now what? What do I do? So what do you do as an advocate or a community health worker if someone brings you this article? And there's no right or wrong answer. Don't be shy.
And Sue, I'll share some of the responses with you as they come in.
Excellent.
Okay. We have talk to your physician, go to the source article, try and find the actual source. We've got a lot of that. Somebody has go through the steps of using X-ray vision. Speak with
I like it.
I know, I like that, right? Check the experts who are cited, confirm validity. So that's the gist of what we are seeing, all sorts of great responses.
These are really great responses. Thank you. What we did at Force was we did check the actual peer-reviewed journal article, and there was one. And we looked at the actual, this was statistically significant finding, but when you looked at the clinical aspects of it, this is a very, very rare cancer. And this was actually a retrospective study. And although the findings were statistically significant, it was still, the risk went up from about, 0.003%, so that's a really small number, to 0.052%. So, probably not much that people would need to do about it, but yet, here we are. Everybody reads Huffington Post, or a lot of us do. Hard to escape seeing a headline like this. So, again, just to give you an example that, definitely going to the source, using your X-ray vision, all of that, excellent. Just taking a few additional steps to figure out what the research actually said. So we'll go to our last poll, and then I'll open it up for Q&A. I apologize, I went over. But what relevance score would you guys give this research? And if we can cue the survey. Great. We're getting some in. We'll give people a little more time. Excellent. You guys are so engaged. We'll give it let's give it just 15 more seconds. Oh, okay. I just got a schedule to end. All right, let's show the results if we can. And can everyone see the results? Sorry.
Yes, Sue, they've been shared with the audience.
Okay, thank you. This was pre-X-ray, so we actually didn't score this one. But, I think, and the science was solid. And, although it was a really rare cancer, so there's only so much you can do to generate evidence. But, as far as clinical relevance, pretty low, at least as of right now. Excellent. So just a few take-home messages, just that health literacy is an important component of health communication, and we all can do our part. We all have a role to play in improving health literacy. It's not on just the individual. There are things that are unique to the digital space that make them particularly hard for patients to navigate. So it's really important for us to be aware of them and sensitized to it. And when our patients bring us information, that we can help them navigate it and help make sure that it's not getting propagated. And there are tools and resources available to help empower patients, and I provided some of those as well. I think, Stephanie, that the attendees are able to access that. I do want to acknowledge our partners and really, really, really thank you for your attention and your engagement. You guys did really, really, really great. And I will take in the last 4 minutes, sorry. Any questions? Thank you.
Great. Thank you, Sue, so much for this extremely informative presentation. There's been a lot of great feedback from the audience, and I also really appreciate the audience being so engaged and sharing their insights, just as you have said. So we have just a few minutes for questions. And if anybody is putting them into the chat, into the question and answer box, that is the right place to put them. So please continue with that. And we ask that you try to frame your questions generally so everybody can benefit from your answers. So I think, Sue, probably in the interest of time, we should just focus on one. And so I'm just going to go with this one. And again, thank you for sharing so much incredible information. And yes, people have access to the resource deck you provided. That'll be posted on our website. And
you can share my email. Oh, sorry. I was going to say you can share my email address as well. And, you know, if people have questions or comments, I'm happy to address them.
Oh, how nice. Okay, great. We will do that then. Thank you. So the question that I'm going to ask, and I know all questions are kind of complicated, and I'm sure, you know, you would have a lot to say if we had even more time. But early on, you had mentioned organizational health literacy. And the question is, have you seen any hospitals or organizations take on system-wide efforts? Or if not, what would you recommend? You know, if systems, in addition to individual practitioners, would want to address these types of issues that you've brought up today?
Yes, and the answer to that is I have, and there's a real movement toward this, and I think that was part of the goal of including it in Healthy People 2030. So this is now a benchmark for, you know, the next decade, that there's an expectation that hospital systems will take it on. The name isn't escaping me right now, but there are a lot of great, the CDC, a couple of other great government agencies have resources that help institutions and hospital systems assess. You know, it's like the 10 attributes of health literate systems and hospitals, and really great document, and, you know, really broken down into 10 easy digestible chunks, and there's actually a self-assessment for hospitals and systems as well. So really exciting. This is like definitely a growing area, and that's a great question. Thank you.
Fabulous, and thank you for answering it. So at this point, that's all the time we have for questions. I feel like this time has
Sorry.
flown. No, I don't mean it that way at all. The time has flown because the information was just so wonderful and engaging. So on behalf of Living Beyond Breast Cancer, I'd like to thank you, Sue, for the important work that FORCE does and for sharing such valuable information with us today. And for the audience, as I mentioned earlier, we will send you a link to the recording and Sue's resource information within the next week. I'd also like to again recognize the Centers for Disease Control and Prevention for their support of this program. And as a reminder, you'll receive an evaluation link via email today. Please remember to complete it no later than June 30th. And for those of you who registered to receive nursing contact hours or social work CEs, it's required that you complete the evaluation by June 30th. And then certificates will be sent to you via email by July 21st. So again, thank you for participating in today's program, and really importantly, for the care you provide to people affected by breast cancer. Please take good care and enjoy the rest of your day.
Thank you. This concludes today's webinar. Thank you for your participation. All parties may disconnect.